I do want to focus a little bit on how does this impact treatment. So knowing all of these things, first of all, always taking a trauma-informed approach, putting the person first, and centering our responses based on that individual's makeup is going to be important across the board. Doesn't matter if that person has experienced trauma or not, but that taking that approach is really going to help the person feel seen and validated. Regulate, relate, reason is a phrase, I think, coined by Dr. Bruce Perry that really reflects that if somebody is struggling in that moment, the first thing we need to do is help them regulate. Because if they are not in that window of tolerance, they're not going to be able to use their brain to its fullest extent. So the very first thing we want to do is get them back into that regulated state. Then we reconnect with them. We see them, we validate them. And it's only after those two things that, if needed, we reason through the situation. We provide consequences or responses, but we can't do any of that. None of that's going to register because that's all complex thinking parts of our brain. So we have to work in this order for things to register. Relationships are protective, keeping in mind that relationships as deemed protective by that individual are deemed valuable to that individual. And then keeping in mind the role of language and memory. Their language may be more difficult to utilize when we're looking at more traditional trauma-focused therapies, and that we might need to be creative in the way that we approach intervention. Resiliency factors, so things like what does success look like for that individual, not defining it for them, being able to find confidence in neurodiversity, that just because society works this way doesn't mean I'm wrong or bad for working that way. Social support, general health, and getting support for those in the network. So caregivers, support staff, things like that, they also need the opportunities to regulate. And so making sure that that is not lost. I think I'll end with this slide. So what we don't know, research is flawed. So we don't know a lot. It makes treatment much more complex when treatments are validated on one population or another, or the inclusion criteria to be included in a research study is you have to have an IQ of this amount before you can participate, or you can't be physically aggressive, or you can't participate. It really narrows down what we're looking at in terms of our options and the effectiveness of different treatments. We can't simplify complex presentations, as we talked about. And what's not really included in the research is how trauma may be understood with those who have traits that are more impairing, whether that's a lower IQ, whether that's less verbal skills. We don't have a great grasp of interventions with that population in particular when they've experienced trauma. In fact, the research really even struggles to say, how do I identify that there has been exposure to traumatic events when that person doesn't have the verbal language to tell us? Our world is so verbal that it makes assessment and evaluations that much harder. The limitations of the DSM leave us forced to categorize clients for funding purposes, and also the danger of overgeneralizing behaviors, minimizing other behaviors so people fit into the categories neat and tidy. And we know, I don't have to preach to the choir, that can cause a lot of problems. And our fields have a lot to catch up to. So I do have a couple other slides just in terms of being more trauma informed. So I'm going to encourage you to look at SAMHSA's website, and there's 6 principles of trauma-informed care, because, honestly, it doesn't matter if you work with a typically traumatized population. These are really important things that we need to be incorporating into our practice anyway. And it's just a good opportunity for us to reflect upon, are we doing the best that we can in all these different areas? So I think I will call it quits there.